We're delighted today to have Annie Friedrich, a colleague who did her doctoral work in healthcare ethics at St. Louis University, and since 2022 has been assistant professor of bioethics and medical humanities at the Medical College of Wisconsin, where she teaches medical ethics to medical students and other healthcare professional students. She also practices and offers clinical ethics consultations there, including in the Children's Hospital in Milwaukee. And Professor Friedrich has done some interesting works published in an array of important journals within the fields of clinical medicine and medical ethics on topics that we think are really interesting, including um, how we negotiate decisions in the clinical context, the place of technology and how it affects us. Um, and today, we've had her, she came yesterday, has been talking to our TMC community about her experiences. And we've been talking about, in part, the challenge and the adventure of clinical and professional formation for trainees, something that she's involved in as well. And we know that trainees, like medical practitioners, are not all doing great. There's a lot of burnout and demoralization. And today she's going to speak to us with the title of Flourishing in the Cracks, Cultivating Moral Resilience in the Midst of Moral Distress. So welcome, Professor Friedrich. We're delighted to have you.
Well, thank you so much, Far, for that introduction. I'll go ahead and pull up my slides. All right, and hopefully everyone can see that okay. Again, thank you for that introduction, and thank you to the Theology, Medicine, and Culture Initiative for this invitation. It's been wonderful to be together, and I'm really glad to speak with you all today about cultivating moral resilience in the midst of moral distress. And I hope this applies, again, as Dr. Curlin was mentioning, equally to trainees and current practitioners, because this is something I've been thinking a lot about in my current role as a pediatric ethics consultant. I'd say anecdotally, I'm just increasingly seeing themes of care team distress come up in the consult. And so I've been struggling with, as one of the ethics consultants, how do we push back against some of this distress? What does it look like to build up our own moral resilience in the midst of the hard work that we do? Because moral complexity, confusion, uncertainty, distress, these are inevitable features of the healthcare systems in which we work. And so they don't lend themselves to easy solutions. But I'm really looking forward today to hopefully, again, see how we can sort of push back against the edges of this distress. And I will ask for some audience participation. So please get your phones ready in a couple slides. I'm looking forward to kind of hearing from you a little bit in terms of our own resilience. So stay tuned for that. So today we're going to explore some of the moral and spiritual dimensions of well-being and burnout, where I want to assess characteristics of a moral community, identify strategies for building moral resilience. And I'll just say that these are not new strategies, right? These are strategies that are hopefully familiar to many of you. But I think by bringing them into conversation with flourishing, spiritual formation, hopefully it gives them a new sense of depth, and just bringing them into wider circles as well. And again, selfishly, I want to know what's working for you all, what isn't working, so that we can continue to move this forward at our own respective institutions and in our own work. But like any good clinical ethicist does, I need to start off with a case, and this case comes from Prentice et al. And I hope some of the themes feel familiar to you, even if you don't work particularly in these contexts. But we have baby Oliver, who was born at 23 weeks. Within the first week of life, he developed a large bleed on one side of his brain. He has significant lung disease of prematurity and has required high ventilation settings and oxygen since birth. On day 12 of life, he deteriorates further after developing an intestinal perforation and becomes critically unstable. His parents are counseled about his poor long-term neurodevelopmental outcomes, potentially, his critical state, and the high risks of going to the operating room for surgery. The parents are offered end-of-life care, an expectant approach, knowing this would probably lead to death, or a surgical intervention that could also precipitate his death. The family opted for surgery. Jenny, the nurse who has been caring for Oliver the past 3 days, becomes distressed, believing it not to be in Oliver's interest to undergo a laparotomy. She believes the family has a poor understanding of Oliver's current suffering and cannot possibly understand the impacts of his potential long term poor neurodevelopmental outcomes. Nor does she believe that the parents have the capacity to provide the care he will need in the long term should he survive. Oliver is one of 6 children. His parents infrequently visit due to the needs of the other children and due to work. So Jenny raises her concerns with Kira, the neonatologist caring for Oliver. However, Jenny becomes frustrated when Kira informs her that the parents' informed decision should be respected. Jenny believes that Kira lacks what it takes to redirect Oliver's care to comfort care. A unit debrief is arranged to discuss Oliver's case. However, Jenny decides not to go, saying, "What's the point?" and choosing instead to debrief in the staff room with a couple of her colleagues. Now, I think this case really exemplifies kind of a really traditional understanding of moral distress, sort of this idea that you believe you know the right thing to do, but you are constrained from doing that action. And this comes up in nursing distress, comes from the nursing literature, specifically Andrew Jaminton in 1984. And this is really broadened out into much wider circles. We know that all health professionals experience moral distress, but I like this sort of two-pronged understanding of moral distress. It's both when clinicians feel constrained from taking what they believe to be ethically appropriate actions, or are forced to take actions that they believe are ethically inappropriate based on professional obligations, which could result in this kind of sense of complicity in wrongdoing. So it's a push and a pull. It's I can't do what I think I ought to, and I have to do something I think I shouldn't. And this especially is felt when you might have more responsibility than authority, sort of why it came from the nursing literature first. But a lot of clinicians can feel this sort of the push and pull from many different causes that we'll talk about. And so I want to be really clear on a definition of moral distress, because I think it's helpful to know what we're working against when we start to try to push back against it. But of course, moral distress is just one part of this larger kind of culture of ethical practice, because given the complexity of our healthcare systems, the morally pluralistic society in which we live, we're going to face moral adversity. We're going to face challenges. And that can really lead to this sense of imperiled integrity. And I use this map from nurse ethicist Cinda Rushton. And so this moral adversity, this imperiled integrity feels like our actions don't align with our values, or we can't live with a sense of intention and purpose. And that can lead to some moral distress. And that can even further devolve into moral suffering, moral distress, moral injury, moral decline. Moral injury is a term most used in settings of military and warfare, and so it's used not as often in healthcare. I think often the level of harm doesn't rise to the same degree that it might in warfare. So we don't use that term as much in healthcare, but it's certainly becoming more common. And this really can lead to a whole host of negative consequences. So our goal is to say, how do we break out of this moral distress, this moral suffering, and get back into our space of moral resilience so we can have that moment of moral repair and practice with integrity? What does it look like to know we're going to face challenges? We're going to face these moments when our integrity feels challenged, and that can be stressful and very distressing. But what does it mean to go into that space of moral resilience, moral repair, and then practicing with integrity? And again, I give this map and all these little different terms because I think it's helpful to have some language. What is it that we're actually talking about? What is it that we're actually needing to address? And that's really one of the first steps in kind of combating moral distress, is being really specific about what we're dealing with. And that comes too in sort of the root causes of moral distress. We want to be really clear about where the distress is coming from. This is part of an exercise I do with some staff, moral distress mapping, that comes from Denise Dudzinski. And getting clear about where it's coming from is a good first step, because it can come from a lot of different sources. And some of these probably feel very familiar to many of you. root causes of moral distress include a patient or family sort of cause. Maybe we feel like as a care team, we're providing unnecessary or inappropriate treatment based on a patient or family request. Or there's just maybe a sense that we're providing care that's not in the best interest of the patient, when of course best means a lot of different things to different people, but this can cause some distress. There's team or unit root causes of moral distress. Maybe it's a lack of continuity of care, a pressure to order or carry out unnecessary tests or treatments, or even systems or organization aspects as well. Excessive documentation requirements, requirement to care for more patients than we feel is safe, patient care compromised due to lack of resources, equipment, bed capacity. And now some of these, of course, don't have easy solutions, right? It's very hard to say, oh, my moral resilience is going to lead to more beds or more staff, because it's not. And I don't say that to be defeatist, but I think it's important to sort of recognize the limits of what we're up against, and start to sort of highlight and figure out the contour and shape of our moral resilience. What's the space that I can really enact a difference and make a difference, and what are the systems or structures that still need to be changed that I can continually also work towards, but just kind of giving a sense of where we're at with our moral distress, what are the limits of what I can really influence or control, and working within that. Now, again, getting clear on moral distress is the first part. So we're going to get clear on just some more of the negative and the bad of moral distress. Again, some of this might be familiar to many of you. There's this idea that obviously moral distress has kind of these peaks, and sometimes that distress is a little bit resolved. But Epstein and Hamrick came up with the crescendo effect, this idea that there's a residue that remains after these particularly intense cases of moral distress, and it doesn't go away. And in fact, it's building up over time. So maybe you have a really intense patient case scenario, but then the patient is discharged or transferred, or that patient dies. And so some of our distress is alleviated just a little. And we kind of go back to, business as usual, but something's lingering, something's still there. And then we have another spike. Another patient comes in that reminded us very, very similarly to a different case that caused a lot of distress. So we're a little bit elevated. Again, that patient is transferred, discharged, but our residue has been building and building and building. And we know this leads to some really damaging effects. So my goal today is, how do we start to let go of some of that residue or integrate it into our work in meaningful ways so that we can continue to do the work, and not let this residue just crush us over time? Because we're seeing some really striking statistics, even just this year, from the American Medical Association, American Nursing Association. Still very high levels of burnout. Almost half of physicians, more than 60% of nurses are experiencing one or more symptoms of burnout. And this leads to leaving the profession. A few years ago, there was a survey of 2,200 registered nurses. Over half considered leaving the profession within the year. Even in pediatric healthcare providers, almost 36% reported having left their position or were thinking about leaving due to moral distress. And so moral distress is certainly an individual issue, but it's really also a systems issue and a structures issue. And so these numbers are striking in terms of why this matters, right? It matters because we care about our individual staff and our care teams, but we also care about healthy work environments as well. And so I think it's really important to have these numbers sort of in the back of our mind, even as we're going to focus more on sort of the individual practices today. Now, before kind of turning more into those individual practices, I wanted to pull up this image one more time of this culture of ethical practice, because sometimes I think there's things in our experiences that don't fit neatly onto this map, right? Sometimes we're not always feeling such a tension between my ethical values are challenged, or I'm really not able to live with intention and purpose. Sometimes what we just see is sadness, and we bear witness to suffering and hardships and traumas and tragedies. And that doesn't really have a place on this map, but it has a place in moral distress. And so I think it's really important whenever we're starting to think about and talk about how do we work through moral distress, I really want to do this all within a lens of trauma stewardship. This comes from social worker Laura Vandernoot Lipsky, and she refers to trauma stewardship as the entire conversation about how we come to do this work, how we are affected by it, and how we make sense of and learn from our experiences. So she asks us to consider, how do we remain whole and helpful to ourselves, to others, to our surroundings, even amid great challenges. Because to participate in trauma stewardship really is to remember that sort of vocation, that call of why we're doing this work, and maintaining our integrity along the way. But it that doesn't just happen without being intentional about it, without really holding and stewarding the hard experiences that we see day in and day out. And we don't get a lot of this training, right? We don't get to talk with our trainees or our colleagues about how they're holding their trauma, how they're holding the hard work that they do every day. And that's what's, again, leading to this burnout, leaving the profession. And so really building moral resilience is part of this larger conversation of trauma stewardship. So I just wanted to frame it in that way as well, even if you're not feeling a specific tension of ethical values being challenged, there's still something to cultivate and work towards here. And so when in this kind of lens of trauma stewardship, I want us to be thinking about moral resilience. And I think that's just one tool that we can use in this trauma stewardship lens. And I really love the definition from Rushton, who says moral resilience is an individual's ability to sustain or restore their integrity in response to moral complexity, confusion, distress, or setbacks. And again, even though we're framing this sort of kind of moral resilience in the lens of trauma stewardship as an individual practice, I think some critics are right that, resilience becomes, again, just another task for the individual to accomplish or fail to accomplish. And then you become a moral failure for not building up your own moral resilience. And this can be a really toxic and damaging concept of moral resilience. So another yoga workshop or a required wellness webinar might really actually do more harm than good. And so I really want to be mindful and give voice to that critic. But I also don't want us to feel powerless to do anything, right? I think there are things we can do today. There are things I can do today that can change how I practice and how I show up in my work. Lipsky says it this way in trauma stewardship. She says, nothing has to change in the world for us to transform our own life experience. She goes on, she says, we have no authority over a lot of things in our life, right? But we do control how we react and interact with our situation from moment to moment. One of my nurse colleagues talks about this in terms of just thinking about what's in our circle of control. There's a lot of things that we're maybe concerned about. There's some things that we maybe have an influence over, but there's maybe a smaller amount that I can directly control. And some of that is my ability to sustain or restore integrity in response to this complexity, confusion, distress that I'm facing. And so I wanted to just highlight that and caveat that today to say, absolutely, yes, and yes, it's individually, how can I do this to sustain my work? And as systems, we need to create better systems, and we need an ethical climate that allows us to have moral sensitivity to wrestle with these big questions of what is good and right and true. And so these are both happening simultaneously at the same time. But three of the practices I want to talk a little bit about today, I want to think about, how do we look outward to shift our perspective? How do we look inward to cultivate reflection and insight? And then how do we look beside us to connect to meaning and purpose? And again, these are not new practices, but I hope they'll resonate with you in a different way or a new way today. So one of the first practices that I love and I talk about all the time, and whether it's in ethics contexts or medical education or well-being or moral formation, is, do I need to shift my perspective? Especially thinking about that moral distress, that classic definition, like, I think this is wrong. Do I need to shift my perspective? Do I need to shift my moral imagination? Can I consider perspectives of others that are different from my own? So thinking back to our case of baby Oliver, has Jenny considered why his parents might want the surgery? What does, a good quality of life look like for them? What does suffering mean? Has she been able to have these sort of deeper conversations with them? Or maybe Kira, the neonatologist, has, and Jenny just hasn't heard that yet. So can she broaden her moral imagination just a little bit to consider, "Oh, I never thought about it that way." Mm, but that takes a lot of humility. So this idea of epistemic humility, that we have to kind of take a step back and consider what we might not or cannot know about this patient and family experience. I think it's very hard, especially for a lot of our seasoned colleagues who say, I've seen this before. I know where it's going. I know where this is ending up. And that while that's true, we also never live that family's experience. And we also never take that family or that child home, usually, right? We are not the ones day in, day out living with the decision to continue on, the decision to, withhold treatment. There's so many parts of this family and this child's experience that we'll never know. And so that kind of, it takes a bit of humility to sort of recognize that. And there's a humility in saying success might look different for this family than what I'm used to. Can I be open to a different ending? And again, Jenny probably has an idea in her mind of what a good ending is. But can she pause that? Can she kind of stop that in its tracks and say, well, maybe there's a different story here, that one that I haven't been considering. And it's I'm not saying this is easy by any means. This is really hard to do, but this is sort of the first step, I think, not only in addressing ethical conflict or maybe dilemmas, but for helping us to be healthy and whole in these dilemmas and in this distress, and thinking about how do I shift my perspective. I love this quote from sociologist Art Frank. He says, "We are good at making other people characters in our own stories, but the profoundly ethical task is for us to see ourselves as characters in other people's stories." And I think in healthcare, we often do this well. We know that patients come into our lives for just a moment, but it's sometimes at the worst moment of their lives. And then they leave, they get to go home, or sometimes the family member has lost a loved one, and they've died, and they have to live with that forever. But we go home and we come to work the next day. And we care for the next patient and the next. So we usually know that it's the patient stories, but it takes a lot of humility to say, am I making this too much about me? For Jenny, is my lens, are my values really clouding the story that I think should be told for Oliver and his family in a way that's really actually creating harm, not only distress for myself, but harm for the situation. And so I think this is a helpful reminder to, especially in these patient care settings, thinking about the patient and their story. Now, it doesn't mean we want to set aside our integrity, our values. I think that's certainly not what I want to take away either. It's rather this perspective shift, that it's encouraging a moral sensitivity, a moral awareness, just being willing to sort of appreciate the complexity of the situation and say, here's where my values and integrity might be butting up against your values and integrity. And really being willing to sit in that, and sit with that and work through that with the patient, the family, or your other care team members, if that's the case, so that we're just not kind of spewing our distress in unhelpful ways. That's where some of the hard work comes in, of shifting our perspective. The second sort of more inward process, once we've done this outward shifting perspective, trying to gain insight, again, it feels very much sort of like a first step of an ethics consultation approach, where we're getting information, but we then have to turn inward and sort of cultivate our own reflection and insight. This comes from the American Association of Critical Care Nurses. They have the 4 A's to rise above moral distress. And so they say, first, let me ask, what is it about the situation that is causing me moral distress? So again, being clear on what's causing the distress, what's the root cause, what are you bringing into this, your own values and perceptions that's creating the distress. Let's get a little clarity on that. Then we need to affirm, how can I be courageous and continue to act for good rather than withdraw from the situation? Because again, it takes a lot of courage to talk to Kira, the neonatologist, or really to ask here, like, hey, what have you heard from this family? Or I'm really struggling with this. Can you help me better understand? It's easier just to go talk to some colleagues and be like, oh, I can't believe, they're making that decision. I would never make that decision if it was my child. That's sometimes easier in a way to do that. But then after we've affirmed and we're going to be courageous and step into this moment, we assess. Does my distress reflect a moral concern? Is there that value component? Or is this distress kind of coming from the trauma work that I see and do? Is this the tragic circumstances surrounding the scenario? And that could absolutely be true, right? We haven't stewarded our trauma and the tragedy that we see in front of us. So it's coming across as moral distress, or it's coming across as a value, as a value conflict. So how can I assess how to best enter into the distress? And then I act. How can I voice my concerns in the most constructive manner? How do I best care for and show compassion to this child and his or her family? And this is definitely an iterative process, even not only case to case, but within a case as well. We're continually asking, affirming, assessing it, and acting at different points. We're continually shifting our perspective as we learn new things or we integrate new concepts and new ideas. We have to keep doing this work to keep showing up for ourselves, for our colleagues, for our patients, and their families. And so I wish I could say, yep, we shift our perspective and then we cultivate insight and then we're well on our way to addressing that distress. But unfortunately, it's not that easy. I really love this image from Prentice et al., just kind of to give a visual of some of the moral distress you might be holding. Of course, we've talked a lot about these different features of moral distress, whether it's, these extrinsic factors, disproportionate care, just a negative ethical environment, a stressful environment. And it's this idea that moral distress is pouring into your cup. You have a resilience, you have a capacity to tolerate moral distress, but your cup is only so big. You can only hold so much. And depending on, a lot of different factors, how big is your cup? Do you have that flexibility, moral sensitivity, sense of purpose that we're going to talk about, a willingness to engage different views? That's that perspective kind of seeking. And of course, there's always the personal factors, the self-care, sleep, exercise, mindfulness, because what we're seeing is moral distress just keeps pouring in, pouring in, pouring in. And we want to grow our cups. We want to hold as much as we can, but we also need to learn, how do we release some of that distress, right? So that residue that's building up in the crescendo effect, how do we integrate it? How do we let that go? Because you might have had similar experiences where all of a sudden your cup will overflow in a bad way. And it overflows onto your kids or your spouse or the grocery store worker who's just not quite quick enough for you that day. And it sometimes takes that like out of your healthcare, out of your work setting to say, oh, something's going on here. What's going on? And being willing to say, I need to do something about this. I can't hold that anymore. And whether, again, that means, do we make our cup bigger? Do we learn to let go of some of the distress that's going to continually pour in? Or do we learn to work in a way that holds it in a way that we can do this over the long haul? I think that's the work that we're going to be continually working on and talking through throughout our careers. Though the last practice I want to focus on and then do some polling is, how do we connect to our meaning and purpose? This is really one of the most important things. I think it's something we don't talk about enough, the why of why we're here. And sometimes it's really helpful to do this in moral communities. So we have these moral communities or groups of people bound together for a common moral purpose that transcends personal interests and promotes the well-being of others. So these are certainly, healthcare can be moral communities, your unit, your department, your hospital. We're here for sort of a greater purpose. But you also, even though you have a moral community, you want to feel like you matter in that moral community. You want to feel like you make a difference in the lives of others and are significant in the world. So there's both the sense of feeling valued and adding value into the communities in which you work. And so I think healthcare, your unit, think of your unit, your department, is very easy to think of, yeah, this is my moral community. This is what we're working towards together, bringing about health and flourishing for our patients. But those of us in the Christian community, I think it's important to remember that we have this even greater community that we should be relying on and pulling from which to draw strength and meaning. I think it's very easy to say, yes, I know that I matter to God, and yes, I know I matter to my patients, but do I live that out? Do I act as though that is true? And do we think about it, right? We just don't often take this moment to connect to our meaning and purpose. And maybe you do, and I'd love to hear kind of about the practices that work for you. But we get so into the daily shuffle and the daily grind that we really don't take a moment to say, what is my moral community? How am I connecting to meaning and purpose? Or how am I not? Where am I falling short in that? And where am I feeling that stress of not connecting to my meaning and purpose? So I want to take a moment right now in this kind of community of friends that we have here to connect to this a little bit more, to tap into it, to provide a moment of reflection and space, and a way for you to just sort of reflect on your sense of mattering, reflect on your sense of purpose. Just to kind of give us space to start creating more rooms in our cup so that we can hold more. So we have a little online poll here. We're going to have some audience participation. I'd love to have as much as possible. So go ahead and scan the QR code. And otherwise, you can go to menti.com, menti.com. You can enter code 61760913. And then once we get everyone or most people in, I'll progress the slides and I'll have some questions for you all. All right, hopefully everyone's gotten a chance to pull out their phone, scan that QR code. I'll follow along with you as well, pull mine out here. All right, let's go on the first question. I feel like I matter to my patients. How strongly do you agree with that? And even for those of you in training, even just kind of the patients you have been able to interact with, do you feel like you matter to your patients? I'm seeing mostly agree, which is great. Those are the numbers we want to see. But sometimes we forget that we matter to our patients, but it's really important to take this moment. All right, next question. I feel like I matter to my colleagues. Those moral communities that you're a part of, think of those communities and colleagues. Yeah, seeing a lot of agree strongly. That's great. Again, goes a long way in building up towards this sense of moral community and connection. All right, I'm going to go on to the next. We have, how often are you treated in a way that makes you feel insignificant at work? And this is sort of the flip side of connecting to meaning and purpose when we don't feel like we matter. Sometimes. Sometimes even a few said frequently. Some say rarely or never, which is great. We feel like we're really connecting to that meaning and purpose. But yeah, sometimes that can happen. So when do you feel like you matter at work? So we know we've sometimes feel like we're insignificant, but jot down a few words or phrases that come to mind. This is a word cloud. I just want to, what does it feel like to feel like you matter? What are the spaces that really speak to you and you show up and you say, "Oh, I matter here." Yeah, Rounds is a great example. Like you feel like you really matter there. You're doing something. When you're affirmed. Yes, that moment of gratitude, having answers. Or on the flip side of having answers, just being curious. I like that. The curiosity matters. Calmness matters. Being with a patient, yes, that absolutely matters. Updating families, counseling a patient, helping people in pain, listening, people feeling heard at deaths. When people need me, offering ideas. These are all great ways of feeling like you matter. And these are all right. There's not a one answer, which I love that we can pull on this source of feeling like you matter at work. I love that. And then lastly, why did you become a healthcare professional or whatever field you're in currently? Why did you get into that work? Um, and whatever level of training you're at, why did you start down this long road um, to where you're headed? Vocational calling, call to help, to serve, that vocation. I became a healthcare professional because of Jesus, to be with the suffering, to serve others. Kids seem to matter. Compassion, desire for more, fulfillment, ambition, community. Hmm, these are great. Paying the bills, that's a real one. Yeah, and that's not it doesn't mean that you don't care about the work you do, but that's a real I'm so glad someone put that. That's a real life, why do we do the work that we do? To sustain this is, we gotta work. Sometimes we're always learning. Emotional support. You have an interest in it. Yeah, you're pulled to this, to heal, to support your family, ministry in the trenches. Yeah, these are all really, really great. Thank you for journeying with me through that. And I hope it's again just a moment of letting yourself feel and ask, why am I here? Why am I doing this? Because without those moments, I think it can start to feel like we are getting pulled under the waves. Even thinking back to our case and baby Oliver, it's really hard, I can imagine, for Jenny to keep showing up and trying to just keep this resilience and keep afloat when you just feel like you're being pulled under and under and under. But I think there's still moments of goodness even in this work of shifting our perspective and cultivating insight and reflection and connecting to meaning and purpose. Where thinking about Jenny, maybe she did all that work and she was able to maybe not agree, but understand why Oliver's parents made that decision. She could appreciate the goodness of his life, even if she wouldn't make that decision for herself. And I think it's really important to remember that finding a moral solution is not the same as personal satisfaction or personal resolution. So Jenny still might have a sense of distress. She might still not feel like she was able to do what she would have done in that situation, but she can continue to show up for that family. She continues to treat Oliver and his family with compassion, make sure his pain is treated appropriately. And so in that way, this moral resilience didn't eliminate the distress. It didn't get rid of it, but I think it goes a long way in integrating and sort of dissolving some of the residue and building that moral integrity over time so she can continue to show up and do this hard work. I think Cinda Rushton says it well. She says, clinicians of integrity do not escape moral distress or moral suffering. They engage with it. They recognize the ethical conflicts and dilemmas in difficult situations and strive to bring their values and commitments to bear on moral issues they face without having unrealistic expectations of themselves or taking on more responsibility for the outcome that is within their control or authority. Committed to their professional role, they accept the experience of moral distress as a testament to their moral conscientiousness rather than evidence of their moral failing. And she goes on to say, that morally resilient clinicians are inevitably going to be scathed by this experience. You can't get out unharmed. You can't get out without being impacted in some way. And this goes back to trauma stewardship as well. It's realizing that we can't escape trauma. We can't just know that we're never going to see hard things in the work that we do. We have to hold it. And how do we hold that well so that we can continue to show up with our deepened sense of integrity? And I think for Jenny too, there's other questions she could ask when she feels like she's just getting overcome by the waves. I love the questions, what about the situation produced benefit or meaning for you, the patient, family, and sometimes there's nothing. Sometimes it really was just that tragedy, and we have to steward that trauma. But is there something you can is there a moment of meaning for in that case? And what did you do that made a difference for the patient? So often I talk to nurses that said, "Oh, I didn't do anything. I'm not being a good nurse today." And it feels so trite and not substantive enough, but I say you kept them safe and you showed up for them and you were present with them. And sometimes nurses hear that and sometimes they don't. It can be hard to hear when you feel like you need to be doing more. Um, but just thinking, what did I do today that was good for my patient? And taking that with you, taking that home, is really, really an important part, I think, of building this moral resilience. And then I'll just add to it that it takes a lot of courage to continue to shift perspective and kind of ask, affirm, and assess and reassess. It does take a lot of courage. It takes courage from the leadership perspective for those of you sort of in positions of leadership to create moral space, to say, hey, I know this is important for my team. I'm going to do the hard work of setting aside a debrief time or encouraging my staff to attend. And then it takes courage to step in to that moral space. Again, it might be easier for Jenny not to show up and not to have to defend herself or not to have to rehash her values and why she wouldn't make this decision or why she would make this decision. So it's courage. It really is being willing to say, these are my values, these are my commitments, and I need to continue to act with integrity, and this is how I'm going to do it. But it really takes a lot, and then sometimes we'll continue. It won't be enough. It'll feel like we're still failing. So I want to end with this. When all else seems to fail, when we've tried to look outward and shift our perspective, when we've tried to turn inward and cultivate reflection, we've tried to connect beside to meaning and purpose, but maybe the patient still died or my integrity was still imperiled. How do we continue? And I love this activity, this exercise called the Pause from doctors Alicia Pilarski and Cassie Ferguson at Children's Wisconsin. And it's a structured invitation for members of the healthcare team to stop and take a moment to honor a patient who has died and acknowledge the efforts of the team. So this is used in our emergency department contexts. And I'm going to read it for you today, but I want to think about even in situations where maybe you're not working in a patient death situation, or you're maybe the language or wording would be a little bit different to you. Think about what this could look like for your practice. So let's pause as a team. Before we leave the care of this patient, let's take a moment to stop as a group and honor this person that we have been caring for. Name is a person who had a family and friends. They were loved and gave love and were important to others. Let's take a moment to recognize that now and honor this person with a moment of silence. Know that as individuals and as a team, we put forth our best effort to give this person their best chance. Even though they died, it does not mean we failed. We will go on with our day, knowing that we were their best chance and that everyone here did a good job. Know that the next patient needs you, and thank you for everything you do every day. And I love this because it is a perspective shift, a moment of reflection, and a connection to meaning and purpose all in one. And it takes just a couple seconds. So I would offer this to you. What is your pause? What is your moment of reflection? Maybe, again, it's a script, a verse, a passage, a poem. But what can you incorporate to continue to do this hard work of bearing witness to suffering and to sadness? And, I titled my talk Flourishing in the Cracks with a picture of a flower kind of pushing through the concrete. But I think for those of us in the Christian community, it's so important to remember that we don't need to rely on our own strength to push through that concrete. We have such a greater power. We are fed by streams of living water. So a pause for me recently has been Jeremiah 17:7-8, which says, "Blessed is the one who trusts in the Lord, whose confidence is in him. They will be like a tree planted by the water that sends out its roots by the stream. It does not fear when heat comes. Its leaves are always green. It has no worries in a year of drought and never fails to bear fruit. So whether you're connecting to, deeper sources of meaning and purpose from a Christian tradition, or another spiritual or religious tradition, I hope it continues to give you strength, it continues to nourish you, continues to let you take these moments of pause, as you cultivate moral resilience. So with that, I'll pause, and leave room for questions, and I'd love to hear what's been working for you all. So thank you. Let me stop share right there.
Thank you, Annie. Friends, if you there are already a few questions, which I'm going to get to in a moment, but if any of you else would like to ask a question, should be on your bottom right, the button for Q&A. And if you don't see it, then click on the little ellipsis, the dot, 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 and then you should see it, be able to enter a question. Let me start with maybe um, a challenging one. If you don't mind putting your slide back up, Annie, that last slide. Uh,
Okay.
I was I guess it's the challenge. I'm curious your thoughts on the challenge of what seems arbitrary about
Mm,
meaning. And so in that prayer, you have um, you have the words, let's take a moment to recognize now, know that as individuals and as a team, we put forth our best effort to give this person their best chance. Even though
mm,
they died, it does not mean we failed. We will go on knowing we did our best, et cetera, et cetera. And it
mm,
seems to me I would have a hard time reciting that because it would seem to me that as a Christian, that was not honest.
mm,
That it would be more consistent as a Christian to say something like, Lord, we haven't loved you with our whole heart. We haven't loved our neighbors as ourselves, but, um, help us
yeah.
and forgive us and strengthen us to continue this work that
Mm,
we're about. And so it seems right that we turn to what brings meaning in medicine, but it strikes me that as that language is used today in medical education, I think it comes with a sense that everyone's meaning is my meaning and it's kind of like my truth. So
mhm,
it's sort of, we all sense that it's sort of arbitrary unless there is really a good that we're after, something that is genuinely meaningful. It's not just my meaning, but is the reality that we're pursuing. And of course, the Christian story, I think, tells us that that's the case.
mm,
That it's not just we're trying to find our meaning, but we're trying to, whether we know it or not, we're trying to find the one who does give all meaning, or as Augustine said, our
mm,
restlessness, our moral distress is kind of is going to be there until we find the one in whom our meaning exists. So, your
mm.
thoughts on that?
Yeah, it's a great question, and I think this comes from obviously a secular hospital system that everyone can choose to participate in or not. You don't have to do a moment of pause, and I think it speaks to sort of our moment where we and we've been talking about this in even the course of this seminar and this visit that we're scratching the surface. We're meeting people in the middle of what's accessible to them and where, okay, we can get people on board with this. And we're like you said, we're talking kind of about meaning and we're not really giving it its weightiness to it. And I think that is a limit of the healthcare systems in which we work. And one of the reasons why I like the pause, but I would write a different one is because I need that connection to Christ, and I need the deeper meaning there for me. So I think I could say this, and I'm not a clinician, so I could know that we can go on knowing that we did a good job. We can go on knowing that the next patient needs me. Um, we can know that we're going to give this moment to this patient, and then I need to do my further work. I need to do my work of saying, yeah, I need help, and I can't do this on my own, and I can't do this by my own strength, and that call has become more private for me, but I think that's a larger question of how do we integrate that private work into public work as well, into the work that we do as healthcare professionals in any space. So I don't have a good way to do this well, as opposed to saying, yep, this is a format and we need to do more as well. And we need to make sure that it resonates with our deeper sense of meaning, because you're right, it won't feel authentic to those of us that say, no, this doesn't actually resonate with my work as a healer or my work as a physician, or striving towards the good. So I think it's a shortcoming of that for sure.
We had a question, might our confidence in our own moral judgments maybe
Mm.
paradoxically contribute to moral distress? I mean, might it be that if we were less confident and had more humility and tolerance toward those who disagree, that we would that would that
Mm,
might ameliorate, I guess, our moral distress? That's my
yes.
wording of this question.
Sure. Yeah. And from my understanding of the question, absolutely. I think there's a sense that we are so sure about, I know the right thing to do. And I use the word right, not good. I know the right thing to do, and I am going to enact that because of I've been in this role for 20 years, and I know what right looks like. But I think especially in pediatrics, there's that is so hard to define and hard to operationalize and hard to mediate that role. And so for us at Children's Wisconsin, I think a lot of the distress and a lot of the work that we've been doing to sort of work through it is that step of humility in saying, well, maybe you're not really thinking, what does suffering mean to this family? What does suffering mean to you? Maybe you actually haven't thought about this way of being in the world. You haven't thought about this way of living. And part of that comes from too, we just need, I think, sort of the association. You just need to have more people that you know who are living lives that are different from your own. And until we just get more comfortable knowing more people who live lives that are different from our own, we're always going to get stuck in our sort of healthcare context bubbles of this is what it should look like. And again, humility takes a lot of courage too. It's not easy to do.
Um, the the question arises, this is particularly relevant for the students you've been meeting with who are trainees for years to come and are not therefore in charge, so to speak, of what happens, at least what happens
Yep.
by the team. How can they approach moral resilience if they are in more of an observer role? It
Mm.
seems less obvious to be able to say, I made a difference.
Yeah, yeah, great question. I think, and we're seeing this partly why it came up in the nursing literature is just I have that responsibility without authority, and medical students or other trainees might feel even less. I don't have responsibility or authority, but yet I still feel my integrity was imperiled. I still feel I can't believe I participated in that, or I can't believe I had to watch that or be involved in that. And I think that's a real a reality that we haven't actually dealt with a lot in medical education. We haven't tackled that. One of the things that I'm working on, and those of us at Medical College of Wisconsin are trying to work on, is really helping medical trainees realize their own agency. And even though they don't have that, might not feel like they can enact that agency in important or meaningful ways now, they are still a moral agent. And they still have values and meaning making beliefs and structures in their lives that shape their and frame their worldviews. And it's not okay to just ignore that for 4 years or 8 years or 10 years. It's not okay to just say, I just take on whatever values my attending has, because that's damaging. And it by the time you get to the end of your training, you're ready to leave. And I think those are the hardest stories to hear, right? When we have these really smart, interesting people coming in and knowing they'd make a great clinician or a great chaplain, and they say, I can't. I got all the way through, and it's because we're not attuning to these deeper values and belief systems. And again, I think some of us are trying to change that, and we know you can't be a good clinician, scientist, researcher unless you also have this sense of what does it mean to be a healer? What does it mean to be what is your value and why you do this work that you do? And we don't call on those values enough.
I'll just observe that in one of the early slides, you noted different categories of causes of moral challenge or distress.
Mm-hmm.
And it struck me that some of those were feeling helpless. And I suspect that insofar as there's moral distress, it's a sense that people have watched um, others do what is not good and have a sense that if they'd had more courage, they might have said something,
Mm,
but they don't, they're afraid. And
yeah.
so we're kind of grappling with our own conviction about our lack of courage.
Mm. Yeah, thank you for that. Because I also even just like I said, "Oh, I don't want moral resilience to be like, you failed because you didn't build moral resilience." I also don't want, clinicians to feel like, "Oh, I failed because I didn't have moral courage." I think there's a way to say, "Yes, I wish I had more moral courage in that moment, and I will pray to do it better next time." Or moral courage doesn't always mean, speaking out. Maybe moral courage looks like, um showing up for that patient. Like, that's also
Mm.
a courageous moment when you say, "I really don't agree with what's going on," or, "I'm not sure if I understand why we're doing what we're doing the way we are, but I know my patient needs me in this way, and I'm gonna show up for that." Or, "I know my colleague needs me in this way, and I'm gonna be here for that." And then being willing to kind of work through it after, whether it's with your moral community, your faith community, whether it's with a trusted colleague. Um, just letting it fester is the hard work that some of us just are not good at, right? And I think we're getting better at kind of talking about and talking through these challenges. But absolutely, I agree. I don't want it to feel like, oh, you just need to be more courageous, right? It's all of our prayer to continue to show up and do this hard work, and giving ourselves grace in that spirit of trauma stewardship, when we wish we would have done it differently.
Thank you. I will say we've had a number of messages requesting the slides, and I'll just note that this seminar, as our others, will be available on our website in the coming days. And so if you want to come back and revisit something that Professor Friedrich said, please do that. And thank you, Professor Friedrich, for a terrific seminar. Thank you all for your time, and we will see you next time.